Cool. Hi, everyone. Can you see my screen and hear me all right? Yeah. Okay, so I'm going to briefly talk to you about health equities and how we've been using data and reporting as part of our health equities project within the MSK service. Hopefully, this can get you thinking about ways you can use data to improve equity in your service. So, what is health equity or health inequity? Health inequity is described by the World Health Organization as differences in health status or in the distribution of health resources between different population groups arising from the social conditions in which people are born, grow, live, work, and age. Health inequities are unfair and could be reduced by the right mix of government policies. Now, inequity isn't always easy to identify, and therefore, as a service, we have been looking into ways we can identify inequity in terms of accessibility to the service, the patient's journey within the service, and their outcomes. So first, just a brief introduction to some of the things that are important to know when thinking about health inequity. There's been lots of research looking at the factors that contribute to a person's health, with healthcare making up just a fraction. The Health Foundation estimating that healthcare only accounts for around 10% of this. So these are just some visuals which are handy to show what can contribute to a person's health, with many being social and personal factors outside of healthcare. So while as a service, we don't have control over many of these, what we can do is try to create a personalized service that considers the complex number of elements that make up a person's health. What we can also do is be proactive in identifying groups of patients that aren't accessing the service or receiving worse outcomes. Again, there are a number of factors which will contribute to this, such as the examples on this slide. In many cases, these factors can be exacerbated depending on a person's characteristics, such as ethnicity, religion, gender, disability, and age, etc. So, whilst our data and reporting can't be certain of identifying these reasons, what it can do is help identify trends which need to be investigated. So, a really useful tool we can use to aggregate many of these different factors is something called the Index of Multiple Deprivation, or IMD. This is a score calculated by the Ministry of Housing, Communities and Local Government, which is given to each postcode in the country. It is made up of a number of factors which can be seen on this slide. And in our work, we are using this information along with protected characteristics data, which we've collected from surveying patients to try to identify trends. And online, you can find lots of interactive maps where you can put in your postcode and see what IMD you're living in. And I'll post an example of one of these in the chat. I'll probably do that after we're finished. So with all that in mind, we can look a bit more closely at the population we serve and what might be contributing to their health. So on the screen, you've got a few examples of inequity between different groups in Sussex. In Sussex, we have an extremely diverse population, all with different factors contributing to their health. We have coastal communities, which are unique in the fact that they are often made up of older citizens who may suffer from social isolation and will inevitably have more and increasing health problems. Coastal communities have also historically been dependent on single industries such as fishing, ports, and tourism, meaning they're more susceptible to unemployment or work being seasonal. We then have more densely populated urban areas such as Brighton and Hove, Crawley and Horsham, where patients may have less access to green spaces, more pollution, or reduced access to primary care. Then we also have more remote populations in the Mid Sussex area who might have less accessible healthcare or worse transport links. So each of these areas will have a diverse population made up of different ages, ethnicities, faiths, levels of deprivation, etc., with each with unique healthcare requirements. So now on to some of the reporting we've been doing internally. This is a report which is using IMD data along with data from our clinical system, System 1. Along the bottom, we have the IMD deciles, 1 being the most deprived and 10 being the least deprived. And the bars of the graph are showing the average diagnostics, finished appointments, DNAs, and cancelled appointments per referral. And this graphic allows us to quickly identify that out of the 4, the DNA data has the clearest gradient when looking at patients grouped by IMD. So this is a trend for patients from more deprived areas to be more likely to DNA appointments compared with the least deprived. This could be because of several reasons. For example, worse transport links, less flexible employment, such as 0-hour contracts, or worse literacy skills. And feel free to have a think and suggest any other reasons you can think of and post them in the chat. Help me out. So while the data can't give us certainties, it does help us identify potential areas we can investigate and try to improve, hopefully improving the efficiency of the service along with the patient's experience. So data reporting can also be useful in identifying trends which we wouldn't otherwise know about. In this example, we plotted the proportion of referrals we receive into the service, which is the blue bars, against the population data that we get from the 2021 census, which is the orange bars. We can see how there is a disparity between the number of referrals we receive from different ethnic groups compared to what we would expect. And this can act as a starting point and allow us to dig deeper into the reasons why. In this example, the Asian community in Crawley may not find our service as accessible as it should be. So in this example, from this data, we went and met members of Crawley's Sikh community and discovered really useful information about how they access healthcare. Many tended to approach family or community leaders rather than health professionals, and also many in that community didn't use smartphones or the internet, making our online self-referral process less accessible to them. And from this, we are looking to co-design and trial a telephone self-referral system. And this kind of reporting can also be valuable when designing and implementing new processes to avoid excluding certain groups of patients. In this example, we were introducing a new online self-booking process for appointments, and the worry was that older patients would be digitally excluded. This report suggests that older age isn't a determinant to whether a patient responded to their online self-booking invitation, and this report will allow us to keep track of this going forward. We then delved a bit deeper into this data to understand whether all patients were more or less likely to use the online process. The report shows that there is a trend for older patients to be more likely to respond to the online booking invitation, but by calling the service and booking their appointment via the telephone. So from this, we can say that patients aren't being digitally excluded due to age, as they're still able to use alternative channels to book their appointment. And then lastly, I quickly wanted to go through some of the next steps for the project. Due to being a community service, our access to data on protected characteristics isn't as complete as primary or secondary care, but we're in the process of getting access to the Sussex Integrated Dataset, which collects data from a wide range of Sussex services in the hope of making healthcare and work on health equity more collaborative. And this will hopefully allow us to get a much more complete picture of the population we serve. That's just a diagram of how they're getting that information in all the different areas. And then we're also looking into using a tool which has been created for public services called Shape Atlas. And I'll pop a link to this as well in the chat after, in case you want to look into it. This is an interactive map that contains lots of data, including a wide range of health and population data, such as the IMDs I mentioned, primary care locations, vaccination data, population projections, air quality, and even things like key supermarket sites. And as an example, the images on this slide show the areas which can access clinic sites by public transport within 30 minutes. The left image showing Brighton Diagnostic Centre and Crawley Hospital on the right. And then I'll just mention that in the meantime, I've created an anonymized health equity data set for Sussex MSK, which contains all the smart survey data we've got for ICATS, Simplicity data for Mars, the IMD data and System 1 data, which means that any current MSK report which uses patient or referral level data can have a health equities section to it. So that's me. Thanks for listening. Please feel free to raise any questions or ideas in the chat or unmute yourself, or you can just chat to me after.
Bye.
Bye.